Good evening, everyone, and thank you for coming to the third in the series of the sandwich generation. Tonight's topic is going to be about care in the home, and there are, which I think you all know at this point, there are a lot of handouts in the back on the table, which we like you to uh, take advantage of uh, either before or after the program. So, without further ado, I'm going to introduce Paul Doyle, who is with Oasis Home Advisors, and we'll take it away.
Thank you, Karen. Thanks for everybody coming out. So this is Sandwich Generation. It's a panel series, and we bring experts in every month to talk about various portions of caregiving, senior caregiving. We started with the general overview, navigating senior care 101. That and local lifelines, which was the second, are available on the, were recorded, so you can go back and check those out. And tonight we're going to be talking about care in the home and all the things that need to be factored into that. Some things you may not have thought about before, and some things you may have. And the idea of the whole series is to get you thinking and to start conversations and to introduce you to local experts, so you know who exists and who's out there, and who, when you do have a question, you would know who to turn to. Um, we've started this series. My wife Susan and I own Oasis Senior Advisors. We've been doing that for about 9 years, and we help families navigate senior care. And our work was the genesis of this series because we spend our days answering all these questions and connecting families to all of these different resources. And so we just thought we'd cobble them together into one coherent thought spread out over 6 months, and see if people reacted to it, and they have. So this is the third series we've done, and let's get started. Tonight, joining us is in the middle, Sheila O'Brien. Sheila O'Brien has owned and operated O'Brien Care Management Services for the past 12 years. She and her team of nurses help clients and their families navigate the very complex medical world, managing their homes in a safe and efficient manner, helping during medical appointments, and managing medications and caregivers. She earned her Bachelor of Science in nursing from Fairfield University and holds licensure in the states of Connecticut and New York as a registered nurse and certification as a certified care manager through the National Academy of Certified Care Managers and the Aging Life Care Association. On the near side is Steve Gregory. Steve Gregory is the owner of Oakley Home Access, Connecticut, and is a Connecticut licensed contractor and certified aging in place specialist. Steve's daily focus and passion stems from his background with a degree in kinesiology and exercise science and 20 plus years in data center construction experience. He is an education first community resource to physical mobility, accessibility, and home safety. On the very end is Jeffery Farmer. He is co-founder of the Center for Transitional Living, which is a multi-state agency providing care and support services for people with mental health needs, acquired brain injuries, and developmental disabilities. Before launching his agency, he worked for the state of Connecticut's Department of Social Services, helping families access public assistance programs and connecting them with community resources. His work today is rooted in a deep understanding of how systems work and sometimes don't, both from the government and the provider perspective. So let's get started. Steve, I'm going to start with you. You are what you get into design, but we also talk about medical equipment in sort of in the home and things we do in the home. What is DME and durable medical equipment? Can you talk a little bit about that, just at the broadest level?
Yeah, absolutely. Thank you. So at Oakley Home Access, the way that our model is designed is to be thinking about obviously the individual and their family members and the condition of their mobility status, whether it's health wise, specific to their mental state or their physical abilities. And we are there to work in a collaboration with their care provider organizations and team members, whether it's their primary care physicians or a rehab team or nurses, social workers, and things of that nature. And we collaborate to design an overall solution for the actual home. Uh, the folks that I work with are looking to maintain their independence, if you will, and want to remain in their home for as long as they possibly can. And what I'm there to do is sit down with the families and understand a little bit more about, their overall surroundings, their overall daily challenges as it relates to their mobility status and getting into the home, around the home, up and down staircases, wherever they feel as though they need to be most comfortable by being in their home. So we modify the actual home. So with that, there is specific equipment outside of the actual construction phase of something that might need to take place, and it doesn't necessarily always have to. So durable medical equipment or anything that would be accessory, simple things like being able to provide a grab bar or two in the bathroom. We find that most folks are finding that bathroom spaces are a little daunting at times, and getting up and down off the toilet or stepping over a tub to get into into their showers, things of that nature, and they're just looking for something simple to grab onto that is strong and sturdy and reliable. Um, we go into the principles of looking at certain rules to follow, things that you don't necessarily look at on a day-to-day basis, that we're trying to provide that information and education around, just a little bit more awareness of your surroundings, things like the floor mat that's in front of your tub that becomes a very slippery hazard. Things that we can be evaluating to make that determination as to what are some of the fast, easy ways to do that. But durable medical equipment would be things like your walkers, your canes, your wheelchairs, and any other devices that are easily attainable and useful for your improvement of your status of mobility. And so, you we would then walk through again with the care team as to maybe the door that goes into their bathroom or bedroom or some part of their living spaces isn't wide enough for that medical equipment. So both we have to look at both the individual's ability, the medical equipment that might be necessary, and it's not medical equipment like for you know uh, looking at a hospital bed entirely with all the monitoring systems and things of that nature. We're just talking about daily activity types of equipment to be able to get around the home. And again, with that might be, hey, I've got a 26-inch wide wheelchair that I need to bring into my door. Getting into my bathroom is only 22 inches wide. What do I do? All right, I don't want to walk that distance, or it's challenging for me to do so, and there's nothing for me to stabilize myself as I go through there. And so it's a wide range of different things that we look at. There's no one way. Everybody ages differently, and everyone has different things that they're concerned about. And it really just is kind of taking an approach of, while the medical equipment serves many folks, it's really about that individual's head, shoulders, knees, and toes, and everything that goes with it.
Thank you. Sheila, tell me, geriatric care manager, we're all very intimately aware of it, but I don't think everybody is. What is a geriatric care manager? What does a geriatric care manager do and what don't they do? And give me a broad sense
Thanks,
of
Paul. So this is a question my husband asks me every day. What
that.
do you do all day long?
Yeah.
And what we do, we're a team of nurses, and what we do is we work with people and our clients and their families and loved ones to coordinate any kind of care that they might need. It could be having their home modified to make it safer. It could be medication management. It could be us going to doctor appointments with people and being that medical eyes and ears in the home. We're often called in because people might need to start having a caregiver and they're just not sure how to go about that. And we coordinate all of those things. There's really any aspect of anybody's life we do help coordinate.
Okay. And Jeffrey, I want to talk to you about caregivers, right? It is this sort of amorphous or broad category succinctly because it's complicated. The range, we talk about home health, we talk about companions, we talk about aides. Give me give me the 10,000-foot view of the range, the continuum of people that will be coming into a home to help somebody.
Sure, sure. So, primarily, we focus on the Medicaid aspect. That's probably maybe 85% of our staff are working on the Medicaid side. So within there, you have, PCAs, personal care assistants. They're focused on bathing, feeding, grooming, clothing, kind of those five key cores. And then the scale would be, I don't want to say coming down, but you have companion after that, where you're not as much hands-on as the state perceives the services. So, personal care assistants, companion, homemakers who are dealing with more light housekeeping, not as much hands-on. So there are different scales in the type of staff that you receive. Um, we also have private care services where it's very similar. We try to model the same thing where the type of caregiver you need, we try to match with your current caregiver. So getting a assessment by a professional is often very important because you don't want to, from our perspective, we have about 225 employees. We have to select the right person for the job. We can't just send the person in there that has no experience with those type of services. So it's very important to acknowledge the care needs and then finding the right staff and linking the two to make sure that you're following the care plan as needed. So again, we try to model everything as the Medicaid waiver would look at it on our private care side and also on the Medicaid side, just so everyone's on the same page following the care plan. But it is try to stress that the right staff for the right sort of level of care that you need.
Okay, great. Now, I'm going to go down with the three of you. We hear everybody says, I want to stay at home. And for good reason, and that's what we all want. But within your different discipline, what does that mean? And what do you hear from people? Like, what are the most common misconceptions they have about staying at home and the hurdle based on I need to do something to my house? What is the thing that they miss?
I think one of the things that I see happen quite often is that when somebody says, well, of course I want to be home. I've been here for 30, 40 years. I don't want to go anywhere, and I'm not interested in, going somewhere, a community or what have you, because it's strange and I want to be home. And what happens in some cases is that you become isolated in the home because they're not able to move up and down floors. They're not able to get into the areas of the home as well as they used to or at all. Um, so the limitation and the constriction of being in the home is something that they haven't really paid a lot of attention to. Or if it's brought to their attention, well, I'll just scoot down the stairs on my bottom. Okay, how about scooting up those stairs? That's a reverse action. That's a little bit more difficult. So just thinking things through because you haven't had to do that before, and why would you? So it's not just a natural thinking process to think about all the things. We walk around the home and we're like, oh, that's dirty. I better get to that task. It's been on my list for 20 years. But we all do that. But that's something that generally would impede their ability to stay in the home. Is not something that we want to consider often. We generally tend to just kind of maybe push that aside until it's really relevant to their ability to be safe. And the safety is the piece that I find that I say, it's fine. Everything's fine. It's okay. And that first fall or that incident changes perspective. And what we're trying to do is just be proactive in that manner. Because in that particular case, when I say, why would you have thought of that? Why would that have been something that you were considering? Is really the care of everybody that is entering into the home to make some some notifications about, hey, this space right here, you are only on the second floor. You have not come downstairs in 3 months. And there's a reason behind that for sure, but there is potentially answers to helping solve that problem. But it's really about the limitations, isolation areas that, from a mental health perspective, begin to weigh on individuals more as much as the physical characteristics that we see.
Sheila, what do you say? What are the common misperceptions people have about how easy it is to stay or how difficult it is to
To
stay at
stay
home?
at home.
Yeah.
So it's not about staying at home, it's about being able to get out as well. And it's about being able to make sure that your medications arrive and that there's food and there's a clean atmosphere, and a safe atmosphere. So it's really, you have to take a 360 look at it. It's not only looking at, um, how is somebody going to get up and down the stairs? That's one component. It's a big component. But it's also about how are they going to get all their meals? How are they going to get in and out of a car or their garage? And I think you'll agree with me. There is nothing that cannot be set up at home.
Of course.
No
Anything's
matter
possible.
how
But
difficult and how compromised somebody is, you can modify a home and you could bring in the people that and the components that are needed. But I think it's very good to have an outside objective set of eyes and ears looking at the environment and putting together all the different pieces that you need in order to be able to stay at home, in order to be able to go out, in order to be able to enjoy yourself and not be isolated.
And Jeffrey, for you, with caregivers going into a home and somebody says, "Oh, the only piece I need is I'll have a caregiver," and it's going to be broad and open ended, and it's going to solve all the problems. But what do they miss in saying,
Yeah,
"I'm going to bring in a caregiver"?
I think the other piece too is the privacy. You're kind of giving that up when you have a caregiver outside the home from an agency coming in. And then maybe even before that, you have a spouse, a daughter, a mother, maybe not mother, but you have someone else that's being a caregiver in that place. And that's different because the role is different now. You went from a family member to a caregiver. And the shifting of that role comes with, you know, um, difficulties, and you're seeing a person in a different light. Um, so I think you're one, giving up privacy, and there are programs out there like the AFL program, Adult Family Living, that enable you to get paid as a family member, a friend, as long as you reside with the individual, to take care of them. So all the things that you've all mentioned come into play. But kind of when you're in the home, when you're with the caregiver, we're all independent people, right? But you're giving that piece up, and I think people don't realize when it comes to that point that they need someone with them, they need a caregiver. They forget how much of their life they lived independently, and now it's like you're having to be at everyone's. You have to be with someone at all times, or even throughout the day for a couple hours. It's just a different perspective, and so we kind of deal with that every time we do a home assessment, or we think someone might be a good fit for the AFO program. We hear stories that it's just like, I didn't see this coming, but we're happy that we have a family member and someone that could help out. But it is different for the client and it is different for the caregiver.
Great. Now, before any of this starts, before we bring in anything, there are things we can do it ourselves to make the home safer, better. What would be the first tip you would give? The thing I should go home tonight and do, or this weekend, that I could do myself that makes it safer, better?
Try to look at things from a outsider's point of view. Um, if you if you notice that there's a lot of scatter rugs, um, I think you'll both agree that's we call that an orthopedics next vacation because it brings you to the operating room, and it really does change lives in a negative way, at least temporarily. So it's the scatter rugs. It's um, What's in the refrigerator? Is the food old? It's when was the last time that you did something that you really enjoy outside the house? Are medications coming in on a regular basis and you're noticing a stockpile of medications because they're not being taken correctly? There's a whole gamut of things that if you try to take a step back, and what happens sometimes in households is the decline happens over 20 years. So it's a very difficult thing to notice, the nuances that happen. But if you try to just take a step back and see, okay, maybe we need to rethink how everything is configured. Our sunken dining room and living room is just not what we had in mind 30 years ago.
And Steve Hughes, when you go into a place, what are the things that the first things that they can do on their own to bring in? What are the tools we're talking? Grab rails, rising recliner, all these different pieces of equipment.
Yeah,
What are the ones that come in?
things that you don't need anybody to build or construct for you. Amazon.
Mhm.
Quite honestly, there's plenty of things that whether it's a riser chair or a riser on your toilet seat with some handles on it, some grab bars, the area rugs, throw rugs, things that are in a wet or slippery condition. Even as you step outside, your welcome mats, things like that. What condition is that in? Is that something that might be a tripping hazard, or it's so old that the corners are flipped up and you're going to trip over that unknowingly? That happens quite often. I think clutter is certainly an area that, again, as you say, it kind of aggregates over time, and having somebody with a fresh perspective just to better organize the space. Um, you know, Getting the bed rails, something like that. If you find that you may be either falling out of the bed, or as you try to get up and out of the bed, there's nothing really, the nightstand or next to you maybe not being the best spot or the right height for you to stand up properly. There's things that you could do to your current bed without having to really make a big investment to handle those types of things. You know, I think relying on um, your another area would be something like the door handles, the round doorknobs. They're very difficult to grip and turn them into levers, things of that nature. Sliders, you know, what's the locking mechanism for your back door? Are you having trouble with that switch? So maybe some simple things, a little maybe slightly more advanced, but you're not knocking down walls. You're not, putting a Hoyer system or a lift system in the rafters of your home. You're handling the bathroom with some easy grab bars, some lifts. If your favorite chair is a recliner and you wanted it to rise up for you and lift you up, there are those things that are available out in the marketplace that you can handle for yourself and get some support and some recommendations as to what might be the best type of equipment for that. But those are home related things that are very easily acquirable, accessible, if you will, to anybody. There's nothing special that you would need somebody like myself or the resources that I work with and manufacturers and things of that nature that you have to spend a lot of time and money to help. That, yeah, please.
One thing, though, is don't you think that it's important to talk to a professional when you're doing any of these things? I'm just saying, like, one example is I had somebody that went out and
Hmm.
bought suction grab bars
Correct.
for their shower, did not put them in correctly, and had a fall as a
Correct.
result. And if they had spoken with somebody and just got the advice about how to place things and what are the safer ways of doing things, like how do you feel about uh, railings that are removable, stair glides that are removable? Sometimes they're safe, sometimes they're not.
Railings as in stair rails?
Stair guide.
Yeah. So absolutely, that is not for your everyday person to be implementing.
But
Um,
you can go on Amazon and get this.
you
Well,
can buy
let
them.
So I'm
You
just
can buy them
cautioning
used. You
you.
can buy them all over the place. But I think anything that I say goes with the pretense that I should somebody, a professional of some sort, should be consulted. Somebody that could at least understand what it is that you're thinking about and concerned about, what you might need. We take down more of those suction grab bars in bathrooms and just throw them right into the bathroom.
let me frame it a different way, because the question we say is like, why, I got a guy down the street.
Yep.
He's
Handyman.
he's a handyman.
Yep.
Very handy, helps us out a lot, but we're getting into a thing that he's not the right person for this job. And give me some ideas. We're talking about the grab rail, so that's one thing. What are some other things? Like, I'm gonna have a handyman just redo my bathroom, and that'll be good. I'll be good. I'll be solid. What am I gonna miss by doing it that
Yeah. So again, like when you are just going with a handyman, it's generally looked at from just a what's quick, what's repairs, what are simple things that we can get done in a few hours or what have you. But as it relates to anything that is again non-medical as far as the impact to the home, but there's, as you say, the more complex things that absolutely require not only the proper assessment, there might be some things that might need to be permitted as well. So some stages of a more advanced consultative approach is much more necessary in that particular case. But things like people call them stair glides or stair lifts that elevate you from a floor up into another floor or down into the basement, either direction. And the thing about those is that they are lagged into the actual staircase. Okay, the condition of that staircase is what's critical. If we don't have a proper stair step, depth, height, what's the rise, what's the pitch? Is your footrest going to bang against each step as you're trying to go up and down the stairs? Does it have the right spacings? If I have a door at the top of my stairs, what do I do then? My chair stops too short. I can't turn my chair and get off because I'm not at the top of the landing. Like there's a lot of things that as you go into it that really are important from again from the approach of thinking about it from your own personal safety and those that are caring for you to ensure that as somebody may be in the bathtub situation, there's a lot of answers for that. We can do what's called a tub cut very simply for a few $100. Just literally cut a section out of your tub and then put a divider in there that's watertight, and it lifts out or opens. And it went from an 18-inch high tub down to a 4-inch high tub in that space, and you step right through. That's certainly not something that you're going to understand how to go about doing on your own. You just want to be able to get over that darn 18 inches and get into your tub to bathe, or a chair that would slide you from the external area of that tub, and the chair slides you into the tub area, lifting your feet and legs over that tub, either by yourself or somebody's assistance. So the movement in and out without impacting anything about that bathroom, something like that could be a great assistance. But a full remodel of it, generally another area would be somebody's in a wheelchair and the vanity in the bathroom, they can't get close enough to the water faucets. The water faucets are also turn dial. Okay. We need levers. We need a mirror that's at an angle. So if I'm in a chair, I can properly care for myself. All right. You need the actual countertop spacing so that you can put certain things down there that are important to your medications or toothpaste, toothbrushes, things of that nature. But we want to be able to have access underneath that vanity for a chair to fit. Right? That's not something a handyman is going to understand those areas to be thinking about as he's designing or structuring a bathroom renovation in that particular.
way? Okay, so that's stuff we bring in. Now let's talk about people. So Jeffrey, when I'm I bring somebody in, whether it be, and you mentioned the family program. So if I'm either having a family member just help out a family member who's getting now compensated for this, or I'm going to hire somebody from the outside, what are the considerations I need on choosing that person and defining their roles?
Uh, before I get to that, I just want to mention one thing from a home care agency's perspective, talking about like a home assessment, things like that. You also have to keep in mind that if you are bringing a staff on, either from an agency or anyone from the outside, we're looking at from the perspective of, hey, risk assessment for the client in the home as well as the staff. We also have liability within there to make sure that our staff aren't in the shower slipping around trying to get someone over that bathtub.
Yep.
So my perspective is always saying, okay, before we get any client or we work with anyone, we always do a home assessment. We have someone named David who actually used to work for Agency on Aging, and he goes out and he does our own specific assessment, whether they need any home modification or um, specific extra nursing. We look for things like that where the individual might just think, oh, no, this is how it is. And we say, well, wait a minute, we have this outside perspective. You actually do need the grab bar. You actually do need whatever it is. So just from the home assessment standpoint, I just wanted to add that.
That's okay.
Yeah.
That
So
little
when,
bit.
That's you.
when do I know when things are coming in? People ask us a lot. So when do I know that I should bring somebody in? Whether it's, family member is going to sort of happen organically.
Yeah.
When do I need to make that transition beyond that?
Well, I think it's generally speaking, when we are contacted, it's usually not the individual needing the care. Maybe 10, 20%. It's not a scientific figure. I'm just thinking off the top of my head. But it's around the holidays as well. People start noticing, well, things aren't what they should be. Um, I personally think that um, when someone starts slowing down or they're not themselves or it takes a long time for someone to realize, hey, I might need this, hand up, I need the assistance in the home. um, a lot of the programs that we work with, individuals are resistant. um, it's really more the family that is kind of saying, hey, wait a minute, we should talk about needing extra care. And when you do need extra care, what steps, would you take? You could speak to someone professional like yourself, which is probably the way to go. Um, but like, who do you turn to when it comes to that? So obviously someone like Paul. But at the end of the day, you'd end up with an agency like ours who would hopefully provide services again, with those levels we talked about, personal care assistance, companion, homemaking, that determination is really done by a professional. You wouldn't just say, hey, I know I need personal care assistant hours. Like even when we get private hours where it's not done through the state, we would come in, someone like I mentioned before, David would come in and say, well, here's what you told me. They only need light housekeeping in this, but when I came in and did an assessment, the person needs help grooming, feeding. There's some inconsistencies here. Let's sit down. Let's talk about it. Let's create a plan. So there are steps in between saying, hey, I need care and receiving care. And I know it's a long process. There's no books out there specific to the individual that wants the care. But when you think you need care, I would start talking to professionals like you guys.
And Sheila, I think it's an interesting point Jeffrey brings up. A lot of times it isn't the person asking for care, right? It's the situation
Almost never.
has sort of changed. And so what do you see as the catalyst for when we're going to step up and bring in professional?
So you need to be creative and you need to meet people where they're at. And one thing that, like, I'm just going to give an example. I got called in because husband and wife who were elderly, he had just stopped driving, and he had neurological disease that did not allow him to continue driving. It devastated him. At the same time, his wife had memory loss, and the house was definitely showing signs of neglect. So we brought in a driver. It was an aide, and he would go in there and say, okay, I'm going to drive you to the grocery store. without even asking, open the refrigerator. Let's look through the refrigerator, see what we have, and let's make out our grocery list. That way he could see if food is old and what needs to get thrown away, what needs to get brought in. He was there, and every week I would go and pre-fill a medication box. So he would very casually just go over and make sure that the medications were taken. If not, he would give very gentle medication reminders. It started off 3 hours twice a week, and quickly, because they loved the fact that he was keeping them active and keeping the house the way that they knew the house should be. And it grew to 5 days a week, and then family came in on the weekends. And it worked out beautifully. The children were happy, they were happy. So you have to, like I said, you meet them where they're at. You bring in a driver, or you bring in a cook, a chef. You don't, it doesn't have to be, the word aid is very scary to people, so it does not need to be that word.
Okay. And let's talk a little bit about what that aid can do, the cooking, the driving. I think we need to discuss a bit about what they can actually do. They're superheroes, really, because they come and
are.
they just do and they do and they do things we don't want to do, and they over and over and over again. But there are limits. There are things that they can't do. And so let's start with you, Jeffrey. Like what do people, or what are people most surprised that an aide can't do?
I would say dispersing of medications, you need a nurse for that. And, when you're talking about, put it plainly, if you're talking about looking at contracts for the hours that you're working, look at a nurse's hourly rate compared to a personal caregiver's rate. It is night and day, if not triple, quadruple. So that's the biggest one where it's like, hey, we only need the person to, give the medications twice a day for 1 hour, and that's it. And we're saying, well, wait a minute, we have a threshold. Can't do that. And also, by the way, you need a nurse, and that's a shock to people. So.
But interestingly, if a nurse goes in and you know this,
Yes,
they
yep.
go in and
They can
pre-fill a
pre-do- yes.
medication box, they can tell them that's what they need to take. And
Yep.
and you take it out and you put it into the bowl, and it's next to their water or juice in the morning. It's whatever the routine is. But if that's not in the medication box, the aide is not allowed to open the medication
Correct.
and hand them a pill. If the pill is in a medication box, no problem. If the pill is in a vial, it is a problem. So it's very technical things like that. They're not allowed to do finger sticks. They're not allowed to give insulin or any other injection. Eye drops are kind of I think a lot of people just kind of turn their.
I tell my staff, like, please don't tell me that, but
Yeah,
I understand.
exactly.
I don't want to hear about it, but I understand what needs to get done.
Right. It's tricky.
Sheila, I'm going to turn to you on this
Mhm.
next one. Quickly, the idea of where we're getting caregivers from, they're expensive. It's costs a lot of money to do. So just on a financial level, we'll have some that Jeffrey will speak to that Medicaid can pay for some. Some I'm going to have to pay privately, so I can go and get any number of agencies to get it. I can get somebody from church that helped my neighbor and pay her. So walk me through, 10,000-foot view of the differences of those three approaches. We'll leave the Medicaid approach to Jeffrey, but talk about agency registry a little bit
Sure.
for me.
So just so you know, in Connecticut, and Connecticut's a small state, there's over 1,800 home care agencies. It is a flooded market. And within that, and you'll agree with this, a lot of the aides will jump from agency to agency because everybody is paid on a per diem basis, meaning that you're only going to get paid while you're performing hours. So some aides have their names in multiple places. So the different steps, and I'm going to give a quick example. I hope I don't talk too long. One of my clients came to me after the family received their first month's bill because the mother had a stroke. They went to the church, and the reverend at the church gave them name and phone number. That person set up all of her friends to come in, and they were charging an enormous rate And literally, the night shift would come in pajamas with a pillow and still charging by the hour, and that's just wrong. So I changed all of that and got one person through an agency as a live-in. This person slept through the night or was up once, and we saved her 128,000 in the first year. So you have to be very careful. If you go with an agency, the agency will, that's the greatest thing to do. They will vet the person. They will do background checks. They have an entire huge pool so that if this person is sick and can't come into work, they have backup people. The next, but they're a little bit more expensive. The next tier is a registry. So the registry also has a big pool, but then within that, they will assign a person to you, you pay the registry, and then you become the person's employee. So now you're dealing with the taxes at the end of the year. You don't want to pay under the table. You're dealing with taxes, you're dealing with insurance rates because you have to make sure that it can that any problems that might come up with a person is covered by your insurance. And these are just, we guide people through these. A lot of these are just phone calls that you need to make. But then there's also people that are hired privately because you know that your friend's mother had a great caregiver and they don't need her anymore, so I'm going to call her. And I just counsel people, just make sure that you're doing things correctly. You want to make sure that the person is your employee. You are not, you don't go into hospitality mode, is what I tell people. Make sure that they are there right from the beginning to care for and work. And not, I go in so many times and caregivers sitting at the table and the client's wife is making her coffee. You don't want that. So
That was my mom.
yeah.
She entertained.
Exactly. And that's what they do. I said, you just get yourself out of hospitality mode. But that's an important piece. But in a nutshell, it's agencies, um, directories or registries, and then private pay are the three modes.
Okay. And then Jeffrey, this is on any of those three, it's still expensive because if I need 40 hours a week or if I need 24/7, it adds up. And a lot of people can't afford that. And so there are situations where Medicaid can come in and pay for an aid to come in. Can you speak sort of how that happens and
Sure, sure. So prior to me creating my agency, I worked for the Department of Social Services, where I actually would apply for individuals to get on long-term care, whether it would be in a facility-based or home-based waiver. Um, it's it's a process. We actually, when I first started, I said if someone needs care, I want to be able to say yes. So expanding into the elder care program, the DDS waiver, autism, acquired brain injury. Um, and the mental health waiver program. There's a lot of different avenues you can go. And like I said before, there's not a book to kind of get there. But majority, as I mentioned before, also of our clients are Medicaid based. So what you would do is basically apply for Title 19 Medicaid, potentially get approved, and then even after you're approved, you have to apply for the actual service for what you're wanting to get on, whether that's the elder care waiver or vice versa with the mental health care waiver. But Medicaid will pay for long-term care services, whether it's live-in, as you mentioned, and the rates for live-in compared to hourly are really vastly different. But if you do the Medicaid route, the one good thing I will say, one, it's obviously paid, which free is obviously best. But also you would get a care manager from the state eventually, but they would come on and say, hey, you qualify for this. I did an assessment. I think you should go for live-in. I'm going to assign a live-in agency for you, or I'm going to assign personal care services for you, 20 hours a week, 5 days, Monday through Friday. So that is the route. And I always tell people, even if you think you're over income, I would say it at the state, and I still say it today, you should apply. Because worst case scenario, you get put on a spend down, meaning you're over income or over asset, and then you could get services and then apply the amount of money you pay for those services to the spend down. I've seen spend downs as high as $150,000. I've seen spend downs, as low as like $4,000. So over time, I always tell people, even if you think you're over income to get these free services, you should definitely apply because it's a win-win. There's no downside. And one other piece from what you were saying before, when you go with an agency versus private hire, obviously I'm biased. I have an agency, but I've heard so many stories of what you're saying before that show up even an hour early and be watching TV at the client's house, or they're charging them way too much. It should be live-in rates, not hourly rates. Or, God forbid, there's a fall, someone gets hurt. If you work over 26 hours private private hire, that individual needs to have workman's comp insurance. So there are rules and regulations even beyond that. You should be, watching their hours. It's just, I would also agree with your assessment of you should try to go agency based. I don't care if it's my agency. You should try to get agency based care over a private hire as well.
Great. The one thing that characterize what my expectations if I qualify for Medicaid for home care. But boy, it'd be really great if we had a live-in for mom because then I don't get all the phone calls I get, and it'd be great.
Yeah.
So I just ordered. No, there's an app, and I book 24/7 for my mom. Right.
We're gonna invent that app. My partner's over there, Andy, and we always talk about that.
Like, what are the limitations? This is a disappointment. We deliver this message an awful lot. Somebody says, "Oh, great, I'll get on Medicaid, and will be everything we want will be covered. I'll order what we need."
I sometimes it does work out like that,
Yeah.
where they come in, they do the assessment, and say, absolutely, this is no doubt. We say level 4 is max care needs. They need a live-in, or in the AFL waiver where a family member gets paid to take care of a loved one. Level 4, you're all set. This is a home run. But a lot of times, we it takes time. That's first of all. So we should also address that where the realization between needing services and getting on Medicaid services. I mean, there might be a different presidential election between the two. Like there is a long downtime sometimes, and it could just be based on the worker you get at the state. Um, so it's just important to, when in doubt, like I said before, apply for Medicaid. Once you hopefully get on the waiver, advocate for yourself, advocate for your loved ones, for the type of services that they might receive. Um, and yeah, sometimes it does work out where you get a live in. And I always tell people, we've been around for 13 years now. Um, a lot of staff would leave if you give them 50 cents more for another agency. The good ones stay. But there will always be situations. You should value and rank your agency based on how they resolve those situations and how they communicate. So great, you got the live-in care you wanted, but the person shows up and they're terrible. Now what? So have a good communication, have a case manager, not just with the state, but with your agency that you're working with. And if you're not getting that communication, advocate for yourself, advocate for your loved one, talk to the state, they'll switch agencies, they'll do whatever it takes. The goal should be, if you're on Medicaid and you're approved for services, you should be getting the best care you possibly can.
And so another piece we get is I only need 4 hours a day, maybe 3 days a week. Mom be fine. And we'll do this private pay. So it's no problem. So, and I really liked Mary. You sent Mary over. She was great. What's the sort of reality? I think people miss sometimes what I'm asking for when I ask for 12 hours of a single aid.
You want me to answer?
Yeah.
Okay. So it all depends. And so what's going to happen, and you could probably speak to this better than me, is you're going to call the agency. The agency is going to then look at their pool. And it's not easy because you need to match personality, you need to match the geographical location and the hours. So now you're gonna narrow down, okay, these people are available for the hours that are requested. And those are tricky hours because nobody wants to, well, not nobody, but a very narrow margin wants to just work 12 hours. Everybody's trying to work their full-time shifts, so It's putting different pieces together. Well, you'll go here Monday, Wednesday, Friday. You'll go over to a different place Tuesday, Thursday, and
Musical chairs.
yeah, it is
Mhm.
musical chairs. And you're revolving around the caregiver's personal availability too. So it's complex. It's not nearly you are not going to a restaurant and ordering off a menu. It's much more.
Yeah, it's, a lot of our caregivers are looking for full-time, 40 hours a week, 9 to 5. The reality is no one really needs care like you're working a 9 to 5 job. This isn't like a factory where you clock in, clock out every day, Monday, 9 to 5. So, if you do take that case as a caregiver, you're giving up the rest of your day unless you just so happen to have a client down the street. So that's a good point where um, if you're looking for small, minimal hours, great, that's all they need. But now, you know, have some empathy for the caregiver that's great at what she does or he does. They're giving up a lot just to work those 12 hours because they're not available the opportunity cost to work with a client that needs 8 hours that day. So you might not be getting the best caregiver just because you only need 2 or 3 hours. That's just the reality of it. We try to mitigate that, but that's the person's trying to provide for their family and get 40 hours a week, which I completely understand.
Now, I want to finish up. We talked a little bit earlier about, if you're bringing in somebody, you were the boss as a registry. But regardless, there's somebody coming into your home and providing a service. You are the boss. What do you hear from caregivers about their bosses? What can we learn before we go into that? I want to be a good boss. We tell people you want to be a good boss because they'll perform better for you and they'll last longer. But so what are we doing wrong?
I think it's just listening at the end of the day. They're the ones going in there doing the work. You might do your assessment and then you might leave as a manager. They're there every day. You're dealing with personalities, as you said earlier. This isn't, whenever you deal with personalities, sometimes they don't mesh. Um, but I would just listen to the caregiver, to what they're saying, what they're seeing, what they're hearing. A lot of times we get feedback from the caregivers and they're saying, this person needs more hours. I'm doing so much. I'm there for 3 hours and we're not finished and they still need to go to the store. Or they might get there and say, hey, I'm not really doing much. They're paying out of pocket. Like we should talk about changing the hours so that instead of them being up at night, let's change things up. But listening is the number one.
And making sure that, and you'll agree, that making sure that the client is in charge. The last thing that anybody wants to do is be told what to do, especially in their own home. And that gets tricky sometimes because some caregivers like to take charge, and it's a fine line between being a self-starter and seeing, oh, there's a need, there's dishes in the sink, how about if I wash them, than being somebody who bosses somebody around. So it's a fine line.
Great. Now, we could go on forever, but
Yeah.
we're not going to. I'd like to thank you all. I'd like to we'll open up for questions in a second, but just I want to underline what sort of the purpose of this whole series is that we've now introduced you to three very different professionals who cover different areas of care within the home. And so you know that they exist and you can get to them and ask your specific questions about them and all these resources that are there. And you can do that in much greater detail. But if anybody's got any questions for anybody, yes, ma'am.
Please wait for the microphone. Otherwise, the recording won't pick it up.
What kind of training do the caregivers get? I mean, how to bathe a person, how to get them in and out of a wheelchair. I mean, I was a physical therapist a long time ago. I mean, you really need to know.
Just quickly on the Medicaid side, there is state mandates for our agency in terms of the background that they need to have in terms of our onboarding training for PCA. We also do try to do during the home assessment and meet and greet. We don't get reimbursed from the state, but we always do a meet and greet to make sure that whoever's giving the instructions kind of signs off on, hey, I acknowledge my job, I acknowledge my role, what's expected of me, whether it's wheelchair or whatever it is. So just so that our staff doesn't come back to us and say, well, I don't know how to do this. We've kind of gone through it already. So
But do you have home health aides and CNAs and, yeah, so maybe,
We really just match it to what is required. So if the individual we think definitely would benefit from a CNA, again, I'm speaking more on the Medicaid side of things, but it goes back to matching the right person. We're not going to need give someone who needs heavy care to someone who's just started in the industry, has no experience. We look at the resume, we look at what's mandated with the state of Connecticut, OIG checks. But again, this is more Medicaid side of perspective for staff.
right.
Would it be in physical strength also? I mean, sometimes you have to pick up a patient and all.
Without question.
Okay.
Yeah.
I can repeat.
That's a state.
Are the agencies rated or overseen? I mean, you can speak to the level of oversight. There is not a list of things who's.
No, the number one thing that you want to be aware of is there are lists and registries out there for individuals who are, what's the word? OIG registries, individuals that have committed crimes, abuse, neglect. Those registries are out there. I don't think the state actually comments and ranks home care agencies. Maybe they should. I don't know.
They don't.
They
They don't.
And again,
So
you
much
have to
change,
remember
turnover.
that so many aides have their
Yes.
names at multiple agencies.
Too much turnover.
Right. Oh, a lot.
Yeah.
Yeah, they, many home care agencies are, your
Yeah.
agencies, right? Are covered by long-term care.
You may have more of an issue with the registry as you get through the private hire because they, the insurance companies want them registered and
Correct.
certified.
And even the agencies that would qualify for that insurance have to meet a certain threshold, certifications, background. So it wouldn't just be, oh, I'm a home care agency, now let's try to bill insurance. So they have their own vetting as well. On our side, we have to fill in applications, talk to them. It's not as simple as just, hey, we're going to start billing and we'll send that invoice to the insurance company.
Right. There's an exclusion period. It's a little complicated.
And that's for the long-term care insurance. It's also, it applies if you're talking about Medicare for you're getting coming out of a hospital or rehab. That, okay.
Yeah.
um,
Sage Home Care, you mean?
yeah, Sage Home Care, or, I mean, I've called Sage or Stay at Home. They never said anything about, oh, we'll help you apply
Because they don't.
They don't.
Yeah.
for Medicaid. Well, how are you different from them?
Well, I would start just my background. The reason why I started the company is because while I was working at the state of Connecticut, I noticed people had a lot of questions, weren't getting a lot of answers. So I said, day one, if anyone comes to us, we would help them apply for Medicaid. I mean, we should just start there. They might not have the experience or background to be able to do that. We also work with an attorney if they need help with special needs trust, things like that. That's the front end. I said, if we're going to do Medicaid, you need to help people get on Medicaid as well. There are a lot of different home care agencies out there. Like I said before, there will be issues with whatever home care agency you go with. It's how you resolve them, how you communicate, the follow-up. That's how we try to separate ourselves.
There are lists about which a home care agency would have to be certified by the Center for Medicaid, Medicare
Yeah, maybe.
to accept.
So how do you find it? I mean, this is the first time I'm hearing about it.
Well, it's a good thing you showed up.
Right. No, yes, absolutely.
That's
but-
part of the problem with the system. Is
Yeah.
that I could tell you it's on the web, but
Connect.com. You can go to the state's website.
Okay, I have another issue. I live in New York. I'm right on the border. And my backyard is Wilton. I have problem finding help because of the state regulation. Connecticut people cannot come to New York And where I am in New York, most of the New Yorkers don't want to come to this
Definitely.
area.
Mm-hmm.
Too far from White Plain, too far from Putnam County. So I've been struggling finding. So do you guys handle New York?
Unfortunately, no. We do Connecticut, Massachusetts, and we're qualified in Rhode Island. I would put that right back on whoever you're working with the state. It's their job to, if you're eligible, it's their job to get you those services. So they should be going through a different home care agency every single day to try to get you the care. Like if they're not going to do it, then the next company and the next agency.
Are you a resident of Connecticut or New York?
New York.
Is actually for on the home care side, New York Medicaid is more generous than
So
Connecticut.
do I go to?
You need to
never
have a
knew
good,
about Medicaid. I figure, okay, my income is too high. I cannot get Medicaid. So I never knew that you can really apply for Medicaid
and
get
spend down.
Yeah.
waivers.
Yep.
So how do I even find these?
Well, one person you could start with is an elder care attorney. And then in New York, you need to have what's called a PRI done. And that will tell you how much care you qualify for.
I have somebody, we can talk afterwards. There's
Yeah.
somebody if you're talking about New York, we have somebody you should talk to. Anybody else?
Hi guys. I like to ask questions about like how is it important for a family member when you're getting to that age as a individual that needs care? How important is it to kind of talk to your family or about having setting boundaries with caregivers and everything like that when caregivers are coming to your house? Do you think that's an important part of the job?
Yeah, the family should be part of the plan of care. I mean, we talk about the team that's going to be a team approach. You have the state worker, or state case manager, I should say. For us internal, we have our own case manager, but we want the family's input. We don't want this to be a tug of war of who's in power and who's in charge. We work for the client, and getting family input is super important. That waiver program I spoke about before, the AFO program, which they also have in New York, it's called CDPAP. Even that, it's really important to lay down the boundaries of what's expected, what's part of the care plan, and kind of having everyone on the same page.
Anybody else? Well, I'd like to thank the three of you for joining us tonight and sharing. And please, there's plenty of information on the back table from each of these that if you want to now or in the future or the far future, reach out to any of them and ask questions. I'm sure they'll be available for you. Our next session is May 22nd, also a Thursday. It's called Operating Instructions for Senior Care. We're going to have two elder attorneys, and we'll go over everything legal about senior care. So please join us then. Thanks for coming.